Hello, good afternoon. I'm Isabella Romero. I'll be your student physical therapist today. Is it all right if I run you through some questions real quick?
Yeah, that's fine. Thank you.
Awesome. So my first question for you today is, have you ever been told that you have any like hypermobility with your body, any double jointedness, things like that?
Yeah, actually, it's funny. I've always told that I've had very mobile shoulders, especially when sometimes I've been examined by my family doctor. They could just feel like how mobile my shoulder joints are.
Okay. What about, do you have any history of like systemic connective tissue diseases? This could be things like arthritis, rheumatoid arthritis, anything like that?
No, I don't have anything to that measure.
Okay, perfect. Are we currently using any steroids? Have you had a cortisol shot recently? Anything like that?
I've had a cortisone shot injected into my knee one time because I was just having really bad pain.
Perfect. About how long ago was that?
Oh, that was already maybe 8 years ago now.
All right, thank you. And then any cognitive disorders I should be aware of?
Nope, I'm perfectly sane.
Perfect. Alrighty, I just have a couple more questions for you. Any history of malignancy or bone diseases?
No, so far from what I've been told, my bones are pretty healthy.
Awesome, great to hear. What about unhealed fractures? Any broken bones lately?
I don't have any broken, any current broken bones. I did have an avulsion fracture on my ankle, but that was already what,
All right.
about 8 years ago as well.
Okay, so you're cleared and all good with that then?
Yes, correct.
Any recent infections, medications for infections, anything like that?
No, none.
Alrighty. And have you ever had any deep vein thrombosis or blood clotting?
No, I do not have any of that.
Okay. So from our interview today, what I'm seeing is you have no contraindications, just a couple precautions for doing joint mobilization. So I still really think you're a good candidate for that.
Awesome. Thank you.
Thank you. Have a great day.
Here is our posture observation. The main three takeaways are rounded shoulders, trunk thoracic flexion, as well as forward head posture. The rounded shoulders are likely caused by the lower position of the laptop, and the trunk is in a state of thoracic flexion to compensate for the low position of the laptop as well as the low table. And lastly, forward head posture is likely the case due to the monitor not being near eye level, so the head is tilted forward and down to look at the screen.
Based on the postural observations we made for Jose, we came up with three possible impairments. The first is the pectoralis minor tightness. The tightening of the pectoralis minor can be the main reason for the rounded shoulder position. This impairment can lead to shoulder/neck pain or discomfort, which can often cause a decreased range of motion. The second possible impairment is a decrease in thoracic spine mobility. Stiffness and restricted mobility can be observed in the thoracic spine and is usually an indication for poor posture and trunk thoracic flexion. This restriction can have a negative effect on the cervical spine, which can be compensating due to an excessive resistance placed on it from the thoracic spine. Lastly, we discussed cervical/thoracic spine muscle strain or dysfunction as another possible impairment. This can be seen in people who consistently sit with their heads shifted anteriorly, which can cause forward head posture. This can result in cervical spine dysfunction as well as causing tightness in muscles in that region, namely the upper trapezius. Misalignment in the cervical spine can cause pain, muscle imbalance, as well as a decreased range of motion for the individual.
The first adjustment we made was to add a chair into his workstation to address the rounded shoulders. The chair will facilitate proper posture to no longer place the pectoralis minor in a shortened position over prolonged periods of time. The second adjustment was to add in a lumbar support cushion for the excessive trunk thoracic flexion. This will decrease compression of the thoracic spine for long durations of studying. The last adjustment was to elevate the computer screen to be at eye level. This corrects the forward head posture, decreasing compressive forces at the cervical spine and prevents unnecessary activation of the upper trapezius muscles. That could lead to muscular imbalances.
For pectoralis minor tightness, we can utilize a doorway stretch, which is a static self-applied stretch that utilizes a doorway as a stable anchor, allowing one to stretch their chest by leaning forward into the frame. This stretch improves shoulder mobility and decreases pectoral muscle tightness. 2 to 4 reps for 15 to 60 seconds for each side is recommended. Low intensity and long duration stretch is preferred since it allows for elastic deformation and long-term plastic changes, and the patient will be able to tolerate the stretch and the soft tissue can be held in the lengthened position.
For trunk thoracic flexion, we can implement thoracic extension over a foam roller which directly targets the thoracic spine mobility by reversing the prolonged flexed posture. First, you sit on the floor with your knees bent and feet flat. Place a foam roller horizontally at the mid-back in the thoracic spine region. Support your head with your hands. to avoid neck strain, and make sure to engage your abdominals slightly to avoid biasing the lower back. Next, you can gently arch your upper back over the foam roller and hold the stretch for 5 to 10 seconds or to tolerance and breathe deeply, and then return to neutral by engaging your core and starting over again. Our dosage is 8 to 12 reps with a 5 to 10 second hold as tolerated, and we're mainly focusing on the reintroduction of the thoracic extension through motor relearning. Our rationale for this exercise is to promote the extension of the thoracic vertebrae, which is often restricted due to muscular tightness and joint stiffness. Thank you.
PTs can prescribe a wide variety of exercises to combat forward head posture, and the example I'm going with today is the seated chin tuck. The reason I'm going with the seated variation as opposed to supine, prone, or even standing is because we want to keep our exercises as applicable as possible to the goals of the patient. And in this case, we're trying to improve posture while seated. So I'll start off with a demonstration, starting off in that forward head posture. I'm going to cue my patient into making a double chin and bringing their head back, holding for about 1 second at a time. The dosage I'm choosing today is 2 sets of 15 reps, 1 to 2 times a day, and we want to go for just about a 1 second hold. The reason I'm going with this rep range is because we want to promote tissue integrity and also motor learning, kind of break some of those bad habits formed while sitting at the desk frequently. And with a seated chin tuck, what we're doing is essentially strengthening the deep cervical flexors of the neck.